If
First
there's
of
any query, then just when Abhishek.
yes, good morning, my respected teachers and my seniors. And first of all, I like to thank Cardicon organizers for creating such a quest for the newer advances. And today, what I am talking about is a newer molecule, that is semaglutide, which is a new paradigm in the cardiometabolic management. So, if we see how we proceed with the role of GLP-1 in type 2 diabetes, and we also know how this is evolved and what is its use in real clinical practice. So practically being a cardiologist, we all many a times we see nearly two-thirds of our patients are basically suffering from diabetes. So it is always a difficult situation to balance between HbA1c and prevent hypoglycemia, desire to lower blood glucose up to target values, and on the other hand we have to just balance the weight gain and off target side effects if we consider. So this is a expectation from a newer anti-diabetic or having said so, an ideal anti-diabetic, that it should have a good glycemic control and it should have a low risk of hypoglycemia with minimal off-target effect. And to be positive, if it has effect on weight loss or no weight gain, that will be a better thing to opt for. So let us first talk about this. Slides will take little bit more time because our understanding of diabetes was insulin deficiency and insulin resistance has evolved when Alfonso says that it's not only two things that are involved, it's basically 8 mechanisms that are involved in development of diabetes. The GLP-1 analogs are basically, these are hormonal things and they act on 6 mechanisms of diabetes. Let's take one by one. First is the action on beta cells or pancreas. They improve the function of beta cells, they decrease glucagon secretions and also improves the beta cell function by increasing the insulin biosynthesis. And second is they act on the GI tract. They have an effect on reducing decreasing the GI emptying, and having said so, it causes a decreased assimilation of glucose in the body. Second effect on the renal, this is a protective effect by reducing the natriuresis and basically having a nephroprotection as well. On muscles, they increases the insulin sensitivity. Till decade, we know, since decades, we know practically the metformin has effect, but nowadays GLP-1, we also understand that have impact on insulin resistance as well. If we talk about liver, which is the main, you can say playing a central role in the diabetes, that is basically one of the important, even the you can say it's for the storage of glucose as well as for the synthesis there. So it acts on decreasing the hepatic glucose production, increases the insulin sensitivity, hence increasing the uptake. It also affects the decrease de novo lipogenesis and decrease steatosis. Its effect on cardiac vessels is important. That is practically meant to us is that it causes an increased cardioprotection and increased vascular protection. If we talk about action on brain, which is very important, the most important thing is that it acts on the satiety. It increases the satiety, hence decreases the food intake, and this is the main reason by which it decreases the body weight. So there are observation that when the patients who are kept on 2 oral anti-diabetic agents, when they are initiated on GLP-1 receptor agonist, there occurs intensification of their targets. That means the HbA1c is better controlled, the patient's weight is more decreased, and there are higher chances of discontinuation of one of the OADs. Now this has clearly indicated that GLP can be considered as one of the most effective medication for the management if you want to reduce HbA1c, body weight and pill burden even. So, but the challenge was there, this GLP-1 analogs are basically the larger molecules and they need injectable preparations, and injectable preparations are never, you can say, acceptance for even the physician and even the doctors. So there is always you can say the zeal to develop a molecule which has an oral formulation, and thanks to Novo Nordics, they have this unmet need of safe and non-invasive and convenient mode of therapy. So the challenge was the GLP-1 analog is that because it is a, you can say, a protein molecule. So they got degraded with low pH in pH of stomach, as well as a proteolytic enzyme. There is limited permeability across gastrointestinal epithelium, and there is administration alone have very low bioavailability. That means less than 0.001%. So that means you are paying for a larger amount and getting a very small amount of that drug what you are actually ingesting. So basically this modification was done at 3 level. I'm not going in detail. The first important thing on adding the, you can say, a spacer molecule, they have just increases the binding and that increases the half-life. They have add substitution at 34th position with arginine reduces their degradation, and position 8 again reduces their degradation. So this conformability of the molecule is maintained, and this was the reason by which this molecule become stabilized. But there is still challenge of making it more and more bioavailable. For that we have a snack that binds to this molecule, and that practically increases the availability, bioavailability, and improves the drug that is available. Still the bioavailability is reduced to the value of 1%, but yes, it is practically now acceptable and to the clinical outcome. So there are pioneer series of trials, of which 24 trials of in clinical pharmacology, one is phase 2 and 10 in phase 3 trials, and that included nearly 9,543, of which 570 patients are on semaglutide. So when they compared with all available arms like diet and exercise, they are available with compared with SGLT2, DPP4, GLP-1 receptor agonist, even flexible doses of DPP4 extensions were taken. They are also compared with the insulin users. So let us directly talk about what the results are there. So the basic lifestyle modification, you have seen the HbA1c reduction with this molecule GLP-1, oral GLP-1 semaglutide is to tune of minus 1.5, that is nearly 1.5% reduction. With empagliflozin again it is 1.3, and this is I'm talking about with the maximum doses, that is 14 milligram what is recommended for titration. DPP4 inhibitors when compared, again liraglutide, which is the subcutaneous congener of the same GLP-1 agonist, so there, and then again oral are found to be superior. The renal data with placebo is again in patients who have compromised renal function test. In almost all those scenarios, it is found to have better reduction in HbA1c. So this is considered to be one of the best efficacious therapies. And for all those patients, if you have HbA1c less than 7 at the end of treatment, if you see the proportion of patients who are achieving, they are in almost every arm nearly 80%. What we are talking about nowadays is EMPA SGLT2 a lot more. Even in that case, they contribute to 72%, and in the EMPA arm it is only 47% up to 25 milligram. So this is again change in HbA1c when the higher values are the baseline. If it is more than 9%, addition of this therapy will causes further reduction in HbA1c, that is 2.2. So it is directly related to the what is the baseline values. Now this is the exploratory analysis where we want to analyze time spent in glycemia control, and everywhere with the doses of 14 milligram, it is nearly 40% greater time patients spent in the good glycemic control as compared to EMPA. Now second, if we talk about the change in body weight, so this is in almost every arm compared to even subcutaneous congeners, that this drug is causing nearly 4 to 5 kg weight loss. This is again very good because reduction in weight can have a very positive impact on insulin resistance. This is the analysis on weight loss more than 5%. Again, the data significantly shows that higher number of patients have more than 5% weight loss as compared to other group. If we talk about the patient who are reducing more than 1% HbA1c and body weight loss, this is all you can say statistical analysis, and all combination will show that these two things are practically seen in almost nearly 40 to 50% of the patient. If we see the pioneer studies on terms of how many times it is effective, so even if placebo 9.5 times odds ratio was improved as compared to placebo, and in other arms also it's 2.5 to 4 times. So again this is very good. And now CVOT, whatever we are expecting in fact from anti-diabetic therapy, because diabetes is now a vascular thing, what we are talking about, we have not only consider on glucose control but also on vascular improvement or reduction in cardiovascular outcome. The data what we have today is with the from Pioneer 6, and Pioneer 6 have taken patients who have established CV disease as well as the patients who have practically risk for CV events, and in all those there is 21%, although non-significant risk reduction in these patients. So this is basically what the summary of all the data of cardiovascular, although we have a good SOUL study that will just tell us regarding what we are practically prescribing to our patients, and this will have a better outcome with SOUL study, and we will have more, you can say, confidence in using this therapy. I am just showing the last slide, and this slide is how to take this drug. This drug should be taken empty stomach in the morning with half glass water, should be initiated with the 3 milligram and up titrated up to 7 milligram in a month interval and up to 14 milligram maximum dose in another month interval. We have to advise the patient that if they miss the doses, they do not take it on the same day, they just have to take the therapy or dose on the next scheduled day. Any other medication should be taken on at least 30 minutes later. So this is practical approach of management of nausea, which is practically most common with GLP-1. The most important thing is 80 to 90% patient don't feel it. If they feel it, you stop the therapy, you make them drug free for at least 21 days and then reinitiate. Many a times patient get you can say tolerant to these symptoms, or they do not feel it later. So who are the patient? Every patient who is having risk of you can say who obesity, or patient who you want weight loss for them, it is good. Patient in whom hypoglycemia is concerned, it is good for them also. If patient is already on injectable GLP, you can switch. And if your patient have established CVD or high CV risk, as CVOT data is there, although less, but yes, it is good. In older patient, yes, risk of hypoglycemia is there, so it is again good. So this is basically my summary, and the summary clearly what we have talked about, it has a good effect on reduction in HbA1c, body weight, and all composite outcomes, and reduction in pill burden. It brings about the good, you can say, the scientific breakthrough in the innovation for the efficacy of GLP-1 in oral formulation, and this global pioneer trials have already established the fact. Thank you.
That's good, finished on time. Any short query? Yes.
In the morning, a patient is taking 3 tablets, semaglutide, thyroxine and pantoprazole.
Yes.
Then how he should take?
Okay, so they have compared, they have used in fact, and they have found there is slightly change in the thyroxine levels when these drugs are given. So what they recommend a 30 minutes gap between the first drug to be taken is basically the GLP-1 receptor agonist or oral semaglutide. You have to repeat the thyroid level or TSH values after initiating the therapy, because there is subtle changes, although not clinical evident, but yes, it is seen some interaction with the thyroxine what we are giving. For PPI, there is no interaction that is seen, but although again they recommend that it should be taken at least half an hour later.
Okay, that's all the time that we have. Thank you very much. With the permission of the chair, Dr. Shukla, please.